We are honored to have participants from around the world in attendance, not only in this room, but also viewing online. A few important housekeeping notes for those of you in the room. This program is provided by Integritas Communications and supported by an educational grant from AstraZeneca. To answer polling questions, please use the keypad provided. Your responses are anonymous and very important to the outcomes of this program. Program information, presentation slides, and a link to valuable clinical resources are available in the workbook and on the postcard in front of you. To receive CME credit and as part of our ongoing efforts to evaluate impact and refine future activities, please complete and return the evaluation form before you leave. For everyone joining us online, the system will prompt you to answer polling questions, and the information presented is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. For our live audience, please use the question cards located on your table to ask questions. Ushers will be collecting them throughout the program. If you are online, please submit questions through the Q&A box on the right side of your screen. Now, let's give a warm welcome to our presenters. Dr. Michael Wechsler, Dr. Praveen Akuthoda, Dr. Anisha Dua, and Dr. Jason Springer. Enjoy the program.
Hi, welcome everybody. These are our disclosures. We're going to get into this talk. I appreciate you guys being here today, and I'm going to get things kicked off. So these are our educational objectives. You can read through them. I won't read them because I think the more interesting stuff is the discussion and the content that we're going to bring forward, but these are there for your reference. And we're actually going to start with a pre-test, and you guys all have clickers at your tables. And you won't see the answers until later, but we're going to go through these. So the first one is approximately how many patients with EGPA do you manage each year? None, 1, 2 to 4, 5 to 10, more than 10, or I do not manage patients. Yes. Okay. The next question, like I said, you'll see the answers at the end. But which of the following FDA-approved therapies for the treatment of EGPA were developed to target the underlying pathophysiology that is involved in the activation, recruitment, and infiltration of eosinophils? 1 is benralizumab and mepolizumab. 2 is mepolizumab and tezepelumab. 3 is omalizumab and tezepelumab. And 4 is benralizumab and omalizumab. Okay, number 3 is according to the 2022 ACR-EULAR classification criteria, which of the following criteria increases the likelihood that a patient has EGPA as opposed to another type of small vessel vasculitis? 1, hematuria. 2, mononeuritis multiplex. 3, otitis media. And 4, a positive test for C. ANCA. All right, question 4. In the phase 3 Mandara study, which of the following is true regarding the efficacy of benralizumab in patients with relapsing or refractory EGPA? 1, benralizumab was superior to placebo for induction of remission. 2, benralizumab was non-inferior to mepolizumab for induction of remission. 3, treatment with benralizumab resulted in a longer time to first relapse compared with mepolizumab. And 4, treatment with benralizumab resulted in a shorter time to first relapse compared with reslizumab. Okay, so Question 5, Ellen is a 51-year-old woman who has a 7-year history of asthma and a 2-year history of chronic rhinosinusitis with nasal polyps. In the past month, she's experienced worsening asthma symptoms, necessitating an ER visit, and has noted a persistent cough. Her lab results show significant hyper-eosinophilia. She's currently on prednisone 10 milligrams a day, along with inhaled corticosteroids and a long-acting beta agonist. Which of the following would you recommend at this time? 1, continue her current medications. 2, decrease the prednisone to 7.5 milligrams a day and add a biologic. 3, continue current medications and add a biologic. Or 4, discontinue prednisone and start cyclophosphamide. All right, question 6, we're almost getting done. Approximately how often do you currently recommend biologic therapy for patients with severe EGPA? 1 is never, 2 is about 25% of the time, 3, 50% of the time, 4 is 75% of the time, 5, 100% of the time, or 6, I do not manage patients with EGPA. Okay, and then the last question. Approximately, how often do you currently recommend, sorry, this is non-severe. How often do you currently recommend biologic therapy for patients with non-severe EGPA? 1, never, 2, 25% of the time, 3, 50% of the time, 4, 75% of the time, 5 is 100% of the time, and 6 is I do not manage patients with EGPA. So the difference here being non-severe. Okay. All right, like I said, we'll get back to some of your results at the end of this conversation. We're going to start off with just a current picture of EGPA. And we know that EGPA is one of the ANCA-associated vasculitides with some overlapping symptoms and some distinguishing features from MPA or microscopic polyangiitis and GPA or granulomatosis with polyangiitis. It is a rare disease. When you look at the incidence numbers, it's more rare than its counterparts of MPA and GPA, but it is significantly prevalent in the severe asthma population. And we know that all of these vasculitides are basically associated with inflammation of the small-sized blood vessels, eventually leading to damage and necrosis of those blood vessels and then downstream and organ manifestations. There can be a significant delay in diagnosis because these are rare diseases, and early recognition and treatment is really critical because these vasculitides can cause significant organ damage, and once you reach that damage phase, it's really hard to undo some of those manifestations, and it can be potentially fatal. In terms of just a basic overview, classically, patients with EGPA are affected in their 4th or 5th decade of life, but it really can affect any age group. And it's characterized by this necrotizing granulomatous vasculitis. That's what you're looking for on biopsy, affecting these small blood vessels with an eosinophilic infiltration. Some of the features that help us distinguish EGPA from GPA and MPA, it's sort of stepsisters, is its association with asthma, a strong association with rhinosinusitis, and then, of course, that peripheral eosinophilia that we're looking for. More than 90% of patients with EGPA do have a prior history of asthma. So those are some of the clinical clues that can point us toward that diagnosis over GPA or MPA. In terms of the cost of this disease, there are personal costs for the patients and how much it affects their life, but there's also sort of broader health-related costs. And this just shows you sort of the cost across multiple different domains of EGPA versus severe uncontrolled asthma. And you can see across all of these areas, EGPA costs our healthcare system a significant amount of dollars. Even though it's a rare disease, you can see that when you compare with severe uncontrolled asthma, inpatient admissions, outpatient visits, doctor visits, pharmacy costs, EGPA kind of outweighs severe uncontrolled asthma in all of these categories. But when we think about the individual patient, these patients come in with a wide variety of different manifestations, and of course we're going to get into those in more detail throughout this talk. But you can see here that in this study, the proportion of patients experiencing different sort of symptoms. And on the left side, you've got constitutional, dermatologic, GI, respiratory, ENT, cardiovascular, and all of these patients had basically some manifestations in those different domains. And you can see, if you can read it, some of the specific types of complaints or symptoms that these patients had. Neurologic was a little bit lower, but again, neurologic involvement really can impact patients' quality of life and is a significant burden in those who suffer from it. So it is really a systemic disease with a lot of different sort of manifestations, and many of these patients are experiencing symptoms from many of these different organ systems. In terms of patient perspectives, and we'll show a short video shortly, some of the EGPA-associated symptoms really impact patients' abilities to work, exercise, sleep, and engage in social activities. More than a third of patients with EGPA reported issues with diagnostic delays because people are often unfamiliar with this diagnosis or misdiagnosis. And then patients with EGPA also reported difficulty in accessing treatments due to lack of diagnosis or affordability. So recognizing this disease is extremely important, and then initiating management to try to decrease that symptom burden.
In February of 2016, I have to say I just didn't feel well. I was very, very tired, extremely tired. I remember sometimes just leaving a meal and going to lay down. I also had a really bad cough, but it was just a general feeling of not feeling well. Very achy, very achy. I mean, it prevented me from, you come home from work and you go to bed. Or, I think it was like a Mother's Day dinner. I had to leave in the middle of it, go lay down. So yeah, it does have an impact on your life because you don't feel the same. I think I was I thought, is this my menopause? I should have gone through this already. But it's very emotional. It was a little bit harder to regulate some of my feelings. Everything was kind of like everything was on high emotion. I just didn't feel the same. But the body aches are pretty bad. Driving in a car, driving home, just kind of doing your normal day to day, So yeah, you just feel different. Something's wrong, but you don't know what it is. And there wasn't a lot of answers out there, because it's such a rare disease, 1 to 2 out of a million people. It's not like you're going to go to a dinner party and everyone's going to say, oh, I have Churg-Strauss. It's just something that you don't hear a lot about. So it's also very isolating. There's just not a lot of information. There is now, but 10 years ago, 8 years ago, 9 years ago, there wasn't that much out there. I also joined a Facebook group that gave me a lot of insight. I always read all the comments, and that made you feel, that's less isolating when you can read that other people have it across the world and what they did. That's not the end all be all, but it certainly is another level to make you more aware of what's going on. You just have to really learn to slow down and listen to your body. Listen to what your body is telling you in order to stay in front of it. For me, if I start to get raspy and, during the night, if I can hear myself wheezing, I know I could have a cold coming on and I need to be very aware of it. I keep a stash of steroids, 5 milligrams of steroids at home. My doctor's very aware of it. I step up the vitamin C. I resort to airborne, but just so that I can stay ahead of it. Because if I get just a regular cold, I have it for 6 to 8 weeks. And it is debilitating because you can't sleep, you're coughing, and that's when all the joint pain comes back.
All right, so I'm going to ask you guys, we talked about a couple of the different symptoms and the symptom burden in patients, and I'll just go through the line here. What are some of the symptoms that, and it's interesting because we have pulmonary and rheumatology up here, so people might come in with different sort of clinical presentations. So Praveen, what are some of the symptoms that patients with EGPA report as being the most burdensome when you see them?
Yeah, Nisha, Like you said, we have a little bit of a different mix of symptoms that we're seeing, but recurrent dyspnea, inability to do their activities because of dyspnea, nasal congestion from polyps can be quite bothersome to these patients. That's more common, I guess, but patients who have neurologic symptoms, damage from vasculitis, that's what down the line ends up being more reported as bothersome, but particularly early on with the patients that I see, I think those respiratory symptoms are what are most burdensome.
Yeah. Jason, how about you?
Yeah, if they have severe manifestations like peripheral neuropathy or cardiomyopathy, I mean, it can be very devastating and disabling. More commonly, asthma can sometimes be difficult to treat, and I rely on you guys to help me with that.
Anything else?
Yeah, and I think that neuropathy is often the most debilitating. Obviously, anything that's associated with shortness of breath, whether it's cardiac or pulmonary, these patients have pulmonary infiltrates. That can be quite difficult to manage. The constitutional symptoms, can't get out of bed, exhausted, night sweats, weight loss, all those can be concerning. And then really, once you've made a diagnosis, the biggest issue is the treatment, and that's the corticosteroids and all of the side effects of corticosteroids, from weight gain and anxiety to depression and infections. I'd say that is probably the biggest issue.
Yeah, no, I totally agree with that. I think there's the concerning features from the disease itself, and then so many of the concerning ones once you start treatment that patients are often complaining about when they come into clinic. And I'll pass it on to Praveen here to talk a little bit about the pathophysiology.
Great, thanks Anisha. I know everybody came here for pathophys and mechanisms. I took the liberty of wearing my eosinophil colored jacket to help with learning retention. There's this classic description of EGPA that you see from old literature, then called Churg-Strauss syndrome, about a triphasic stages of disease progression, starting with a prodromal allergic phase where this can be a slow march from months to years, sometimes to decades, of often a lot of atopic/allergic type symptoms and constitutional symptoms. So you might have a patient who, in this kind of classic description, who will have increasing asthma over several years, increasing upper airway allergies, chronic rhinosinusitis. They might have some constitutional symptoms as well, malaise, myalgias, arthralgias. And then potentially progressing into a more eosinophilic phase where peripheral eosinophilia, high-grade peripheral eosinophilia is noted, and then manifestations that are due to eosinophilic infiltration of organs, often the lungs, with symptoms related to waxing and waning pulmonary infiltrates, potentially gastrointestinal, cardiac symptoms, and other organs as well, and then progressing into kind of the rip-roaring vasculitic phase where there's true vasculitis of small vessels and symptoms that you associate with that, and perhaps even some improvement of asthma, but involvement of other organs like peripheral neuropathy, mononeuritis multiplex, glomerulonephritis, palpable purpura, things that are more associated with ANCA-positive vasculitides. But I want to make the manifestations, that pathophysiology, though it's not a perfect correlation by any means. These are just kind of tendencies rather than, I'm not sure, do I might go out?
It sounds like it went out.
Might have gone out. Do you want me to pause? It's okay? Okay, great. So, if on the ANCA negative side of things, there are some that are more, there are organ manifestations that are more due to eosinophilic organ infiltration, cardiomyopathy, the pulmonary infiltrates that I mentioned, GI involvement. Then on the other side, ANCA-positive pathophysiology may be more have more of a tendency to be vasculitic type symptoms, whether it be alveolar hemorrhage from capillaritis, mononeuritis multiplex, rapidly progressive GN. Those are things that we might associate more with ANCA positivity and more of a vasculitic flavor. As far as the role of eosinophils, and I would say roles of eosinophils in the pathogenesis of EGPA, as the name implies, eosinophilic granulomatosis with polyangiitis, eosinophils are critical to the pathophysiology of this disease, both from a vasculitic perspective. In the classic description by Churg and Strauss in the 1950s, they described eosinophilic granuloma, vascular granuloma, and vasculitis under the microscope, and potentially more organ infiltrative mechanisms from eosinophils where they release their cytotoxic cationic mediators that are contained preformed in their granules, those mediators including eosinophilic cationic protein, major basic protein, et cetera, and those can all cause tissue damage by nature of their cationic nature. There's also this, there's a lot of factors that drive EGPA pathogenesis, and we're still trying to get our hands on what's most important, what's not most important, but it's clear that there's a intersection between genetic susceptibility, environmental triggers, in dysregulated immune mechanisms that all interplay for the development of EGPA. From a genetic susceptibility perspective, you see on the top box there some of the genes that have been associated. This is not a monogenic disease by any means. These are small associations with EGPA, polymorphisms in MHC class II proteins like HLA-DR, HLA-DQ. IL-10 polymorphisms have also been described with EGPA as well, or associated with EGPA. There are environmental triggers. When you talk to these patients, they'll often tell you that they had some exposure that seems to be temporally associated with their onset of disease. You can never prove whether that was the thing, but there's a lot of where there's smoke, there's fire. So things like organic solvents, you can see other exposures like UV radiation, infections, silica, farming, et cetera. And then dysregulated immunity, which can be in multiple buckets, either the eosinophils themselves, like I said, various dysregulated T cell subsets, whether it be, more atopic things like type 2 mechanisms like we talk about in asthma all the time at the ATS meeting, dysregulated Th17, downregulated Tregs in an abnormal way, and then potential humoral mechanisms as well. This is an ANCA-associated disease, or it can be an ANCA-associated disease, which implies humoral dysregulation as well, B cells producing autoantibodies. So there's a lot going on here, but there's still more to understand with how these things intersect. And some of our current therapeutic targets, or potential and actually deployed therapeutic targets in EGPA, kind of leverage some of our understanding, particularly of these dysregulated immunity, and particularly in the eosinophil / type 2 space. And in particular, like I mentioned, on the eosinophil side, IL-5 mechanisms are extraordinarily important for everything about eosinophil differentiation from myeloid precursors, migration into the bloodstream and into tissues, activation of eosinophils, infiltration into organs. So the anti-IL-5 agents, benralizumab, mepolizumab, reslizumab, have been particularly critical in EGPA therapies in recent years, with both benralizumab and mepolizumab having FDA approvals. There are putative reasons to use dupilumab as well, the potential for IL-4 and IL-13 signaling being important in this disease through IL-4 receptor alpha, the potential importance of IgE, and omalizumab as a potential therapeutic. Again, that's off-label. And then the importance of rituximab, and particularly in severe disease and induction therapy, and then in potentially maintenance therapy as well, being having direct B cell effects, and then potentially reducing pathogenic autoantibodies. All right, so we got an audience response question. Which of the following organs is most likely to show vasculitic manifestations in ANCA-positive patients with EGPA? 1, colon, 2, heart, 3, kidneys, and 4, brain.
Yay.
All right, we got applause from Dr. Wechsler. Thanks. I just got caught up in the I got caught up in the music. Sorry. All right, so great job with that question. And I'm going to pass it on to Jason to talk about differential diagnosis in EGPA.
Oh, great, thank you. Yeah, so I'll go over the differential diagnosis. Let's see, how do you advance this here?
Yeah, you just got to press it.
There we go. Okay. So we heard about that there's 2 flavors, ANCA negative and ANCA positive, and there's some shared characteristics among these patients like eosinophilia, the chronic rhinosinusitis with nasal polyps and asthma. But then there's things that tend to be seen more with ANCA positive, like glomerulonephritis and peripheral neuropathy, whereas with the ANCA negative patients, more likely to have lung involvement and cardiomyopathy and gastroenteritis. Now, there's some common clinical presentations to be clued into. So virtually all these patients are going to have asthma, and typically this is going to be in adulthood. It'll rarely have that seasonal exacerbation, and it can worsen over time. Almost all these patients also have chronic rhinosinusitis. That's very common. Some clues is if patients require glucocorticoids to get that resolved, or if there's bloody nasal discharge, or if they're getting nasal polyps removed and they recur. All these patients are going to have eosinophilia, typically above 1,500. But just remember that the systemic glucocorticoids is going to mask that, and so you need to find a eosinophil count when they're not on glucocorticoids. Now remember, the differential diagnosis for eosinophilia is fairly broad. There are primary, secondary, and idiopathic causes. So as far as primary causes, so primary hypereosinophilic syndrome is a very common mimic, sometimes very hard to differentiate from ANCA-negative EGPA. And then some other primary causes, including rare familial or genetic causes. And then there's a whole slew of secondary causes of eosinophilia, including EGPA. IgG4 can sometimes mimic it, and other rheumatic diseases, but the eosinophilia really isn't going to be as dramatic as you'd see with EGPA. Infectious causes are important to rule out, including helminths and parasites, scabies, fungi, viral, microbacteria, and bacterial. And then some allergic causes like drug hypersensitivity, so make sure you're asking about any new drugs. ABPA is an important mimic. And then neoplasms, not only hematologic malignancies, but solid tumors, systemic mastocytosis, and Langerhans cell histocytosis. So faculty discussion, which of the infections are you most concerned about ruling out before starting glucocorticoids? Let me start over here.
Yeah, I think there are a variety of infections that could be concerning. Oftentimes, fungal infections can be associated with eosinophilia and can also be associated with pulmonary infiltrates and can also be associated with hypersensitivity in the airways and oftentimes can mimic what we see in patients with EGPA or in patients with allergic bronchopulmonary aspergillosis. Anybody who has any chronic infection, any suppurative infection as well, because we're going to be giving glucocorticoids, could also be concerning. And then there are a variety of viral infections as well that could be concerning, and tuberculosis on top of it. So pretty much all the infectious categories are concerning before you start glucocorticoids, and particularly if you're going to start any of the other immunosuppressants on top of it, because any immunosuppressant could potentially exacerbate, unmask this type of disease.
Yeah. Dr. Dua?
Yeah, I mean, I think I've probably been burned on strongyloides the most. I don't automatically check it, and I probably should. I think I've had a couple where I've seen peripheral eosinophilia, and I'm like, oh my gosh, it's EGPA and not GPA, or something like that, and then I send off the test, and that's what's going on. Yeah, I think the main thing is once you're going to go down the pathway of starting these sort of more heavy-duty immunosuppressive drugs, you just really want to make sure that you're not treating the wrong thing. So broadly ruling out infections is super important, making sure they're going to be able to take the drugs and not have an exacerbation of something that's been sort of hidden or underlying is important. But in terms of what I've missed, it's probably strongyloides.
Can I ask you a question on that?
Yeah.
Do you feel like those patients actually were strongyloides? Because a lot of people have IgG positivity to strongyloides.
Yeah, no, because I treated it and it got better. And I was like, it's not EGPA.
Yeah.
Yeah, I've had a couple of those.
It's one of those oft invoked, and and I've treated it as well. I just haven't always been convinced that that's what I was treated.
Yeah.
Yeah.
I try to keep strongyloides in the back of my mind because those you can get like a hyperinfection if you give them glucocorticoids and potentially make it dramatically worse. So these are patients that you ask about the travel history if they've gone to like the tropics and they've been exposed to contaminated soil in places that don't have good sewage systems and stuff. So in the differential of EGPA, there is a significant overlap with other diseases like hyper-eosinophilic syndrome, typically in your ANCA-negative patients, and then the other forms of ANCA-associated vasculitis, there's overlap in those ANCA-positive patients. So what are some distinguishing features that differentiate EGPA from the other forms of ANCA-associated vasculitis? So as we talked about, this is an eosinophilic-rich disease, both peripherally and in the tissue, which is characteristic of EGPA and not the other forms of ANCA-associated vasculitis. You get that granulomatous inflammation, which you can also see with GPA, but you don't see with MPA. Asthma is a characteristic of EGPA. Now, you can get asthma in patients that have GPA and MPA, but it's a separate process. And remember those characteristics of the asthma that would suggest it's EGPA related. And then EGPA patients can have, in about half or so of patients, a P and MPO ANCA positivity. Now, that's shared in common with MPA, where most of those patients do have an MPO and P ANCA positivity. In GPA, it's typically C ANCA and PR3 ANCA positivity, but remember about 10% of GPA patients will be ANCA negative, and about 20% or so will be P ANCA and MPO ANCA positive as well. Now, the other caveat here is if you get weird antibody combinations, so for instance, if you get like a P ANCA with a PR3, or if you get an PR3 with an MPO, then that's a red flag to start thinking outside of these categories. So for instance, the endocarditis bugs could do that, or cocaine, things like that. So audience question, which of the following presentations would be most likely to increase your suspicion for a diagnosis of EGPA? 1, fever of unknown origin. 2, stocking and glove peripheral neuropathy. 3, late onset asthma. And 4, coronary artery disease. All right, excellent job. Late onset asthma. Now, there are some red flag clinical features that can raise your suspicion for EGPA. I won't go through all of these. Some of these are more kind of non-specific, like constitutional symptoms. But respiratory, these fleeting infiltrates that can occur, and this eosinophilic rich stuff in the lungs. It can cause an eosinophilic peripheral pleural effusions. Any patient that's presenting with myocarditis, I would consider EGPA in the differential. It can also affect the pericardium, causing pericardial effusions. There are other features that it shares in common with other forms of ANCA-associated vasculitis like digital ischemia, palpable purpura, mononeuritis multiplex, and glomerulonephritis. And then I think any patient that's presenting with intestinal ischemia or perforation, you should consider EGPA. As far as musculoskeletal features, it can present with a polyarthritis, which isn't specific for the disease, and typically you won't see frank effusions, but they'll have an inflammatory arthritis type history, and less commonly myositis. And in the eyes, more typically you'll get episcleritis and scleritis, and less commonly a retinal vasculitis. So in terms of our diagnostic workup, so typically this is a multidisciplinary approach. I rely on our pulmonologists, ENT docs, and hematologists, and many others. You try to rule out your eosinophilic and vasculitic disorders that we discussed, investigate the main disease complications, and ANCA testing should be done in all patients. As far as other diagnostic workup to consider, so all patients should get a CBC with differential and your basic chemistries, a urinalysis to look for microscopic hematuria, including evaluation for proteinuria. And if you're able to do it, evaluating the urine for CAS is great to show that that microscopic hematuria is from the kidneys. And then this other workup, depending on the clinical scenario, sputum culture if you suspect infection, a cardiac workup, intestinal workup, and the screening for myeloproliferative disorders. As I mentioned, all patients should be tested with ANCAs. I think IgG4s can be very helpful because it gives you a clue if it's elevated, that may be IgG4-related disease. IgE can be helpful. The other immunoglobulin tests I'll check on depending on the clinical situation. Your infectious tests are important. A lot of these will be guided by your history, but remember parasites, as we talked about, and I think it's reasonable to check HIV in many of these patients. A blood smear can be very helpful if you see dysplastic eosinophils or blasts, and that can help guide you. And then more specific testing, a lot of times I'm relying on the hematologist for those. All patients should have some kind of lung imaging, so at least a chest x-ray, but better yet, a CT of the chest. Also pulmonary function testing, not only to show that obstructive lung disease, but something you can follow over time. I think the ENT guys with their nasal endoscopy can be very helpful. In fact, I think that's more helpful than a sinus CT in evaluating the sinonasal regions. I think all patients should have an echocardiogram just to evaluate for cardiomyopathy, because we do know that is one of the biggest predictors of mortality with this disease. And then abdominal ultrasonography as dictated by the clinical history. So as far as selective diagnostic workup, so I won't go through all of these, but EMG if you have peripheral neuropathy to show that mononeuritis multiplex type pattern. As I mentioned, I think the endoscopy is more helpful than sinus CTs. I'll get selective sinus CTs if I'm suspicious for destructive lesions. A BAL can be helpful to show that eosinophilic rich fluid or a thoracentesis. And then ABPA testing is very helpful as well as potentially a common mimic. If you do have clinical signs of cardiomyopathy or you have an echocardiogram that's concerning, a cardiac MRI can be very helpful, or a cardiac PET. You can pursue an endomyocardial biopsy. I've actually rarely done this because a lot of times I have things outside of the heart that I can rely on to make the diagnosis. And then CNS involvement, luckily, is not a common manifestation. Typically, it's going to be more of a pachymeningitis type picture, and you can get a brain MRI and lumbar puncture if you're suspicious of that. So as far as the role of biopsy in diagnosis, so when feasible, it's recommended, but it's not always essential. And I have to say, when I have ANCA-positive patients, a lot of times I need the biopsy less than if I have ANCA-negative patients. And some of the biopsy sites are listed on the bottom here. The kidney and the skin can be very high diagnostic yield, so they can show features of vasculitis, and you can see that eosinophilic rich infiltrate. The other biopsies, the ENT, lung, GI, can be very helpful as well. It's not as common that you're going to see the vasculitis, but you can see granulomas and that eosinophilic rich infiltrate. Now, more recently, the 2022 ACR-EULAR classification criteria have come out. And these are classification criteria, so they're used for research purposes. And so they have some limitations when you're using it for diagnostic purposes. And I think the caveats here on the side show you these limitations. So you use this when a diagnosis of small or medium vessel vasculitis has been made, and an alternative diagnosis mimicking vasculitis should already be excluded. But it helps you, in your mind, develop a framework on how we diagnose this disease. And so you notice that there's a high score for obstructive airway disease and nasal polyps, as well as mononeuritis multiplex, and also if there's an eosinophilic rich infiltrate in the tissue or peripherally. Now notice here that if you have a C-ANCA or PR3 ANCA positivity, there's negative points here. So it's very rare for EGPA patients to have C-ANCA or PR3 positivity. So faculty question, what do you find most helpful in differentiating EGPA from other eosinophilic diseases? Any red flag symptoms or laboratory findings? We'll start with you.
Yeah, you know, I think In particular and I think it's maybe suspect it's a little different from the rheumatology practice perspective than the pulmonologist perspective, but in particular, I'm looking for escalating asthma. It's not always the case, but refractory asthma and plus minus some refractory rhinosinusitis, I think is more typical than EGPA than the other eosinophilic diseases that you're often weighing against EGPA, particularly hypereosinophilic syndromes. There can be some overlap there with ABP as well, but when you're really thinking about a high-grade eosinophilia, even more out of proportion than what you would see in ABPA or in severe eosinophilic asthma, you're really often weighing EGPA versus hypereosinophilic syndrome versus chronic eosinophilic pneumonia. So, eosinophilic pneumonia can have some asthma component to it as well, but in particular, though, I feel like that HES versus EGPA is differentiated by airways disease. And I think that's why you see +5 points or however many points, +3 points in the ACR criteria for obstructive lung disease.
Yeah, I mean, generally, other eosinophilic diseases don't have ANCA positivity, so that would be one. And then, in the presence of actual vasculitis on a biopsy would differentiate EGPA from other eosinophilic disorders. So if you've got asthma, eosinophilia, and extrapulmonary manifestations with characteristic vasculitic features and ANCA positivity, that would distinguish you from another hypereosinophilic syndrome.
Though you're often not going to have all of the ANCA positivity, right? Especially in our
No,
practices.
I'm saying,
but I'm sure not all of them come up with this all the time as we do, right? We don't have the ANCA positivity. Like, what is this?
So I'm saying if you have any of those features would suggest more EGPA rather than other hypereosinophilic disorders.
For sure.
From a rheumatologist standpoint, I like to see the vasculitis. If I can find the vasculitis, then it helps really limit my differential. So.
Yeah, I mean, I think, of course, the biopsy is great. Lab tests, ANCA positivity is great. Those make it very, clean and a lot easier. I think really you're looking for systemic manifestations, right? So if you just are doing a good review of systems on a patient that comes in with kind of refractory asthma, that needing of steroids all the time to get things under control is a clue. And then just really asking about, people don't always bring up skin rashes or their foot feeling heavy, honestly, and so you have to ask about it to pull out that history, and I think those are the things that really make you start thinking about a more systemic process.
To some extent, it may not necessarily matter from a treatment perspective, as I'll talk about, because if you're going to be targeting the eosinophil in particular, you might use the same treatments for EGPA as you do for other eosinophilic disorders. Obviously, after you've excluded other things like infection and drug reactions and malignancy, et cetera.
One of the caveats I'll say there, though, is the cardiac mortality, right? So with the EGPA, you want to make sure you're screening. I know you were talking about sort of the differential and baseline workup, but with cardiac issues being that high cause of mortality in EGPA, that's one thing that you wouldn't want to miss.
Yeah. Well, that is a good segue into going into treatment.
Great. Yeah, so I'll discuss a little bit about individualizing treatment for patients with EGPA. And I think the first question is why is it so important to individualize care for patients with EGPA? Well, it's because the disease is very heterogeneous and every patient may present differently. One patient may present one way with some, mostly airway manifestations. Another may present with other manifestations. Some are ANCA positive, some are ANCA negative. And so it's quite a heterogeneous disorder that can present quite different clinically. There's some patients who've had symptoms for years and other patients who've had symptoms for weeks to months, and they might have different damage profiles as well. And so it's important to take that into consideration. Oftentimes, the constitutional symptoms are present, and that can be bothersome to patients. And the disease severity is a big, big issue because some patients have milder presentations. They may have only asthma, and when I say only, I mean it's not, as if that's good. Asthma, sinus disease, pulmonary infiltrates, and eosinophilia, where you're talking a bit more of like a chronic eosinophilic pneumonia picture. And others may have full-fledged vasculitis in multiple organ systems, whether it's the heart, the nervous system, the GI tract, or the kidneys. So it's important to evaluate and ask what type of disease does each patient have, what are the disease manifestations, so that you can identify and give the right drug to the right patient, and so that you can evaluate response and make sure that the response that the patient's going to have will be appropriate and adequate for what's going on in that given individual. A lot of patients and providers ask about prognosis. And there's been this 5-factor score, which has evolved over time. There was initial 5-factor score and now a revised 5-factor score, which give a sense of the prognosis with this disease. It was established for other vasculitides, but in general, patients who have cardiac involvement, patients who are older, patients who have renal involvement, GI involvement, and interestingly, absence of ENT manifestations, those are patients who do worse. If you have one of those, then your prognosis is worse in terms of survival compared to if you have none of those. And if you have 2 of those, your prognosis is even worse. You can see the cumulative survival out to almost 2 years is down to about 25 to 30% in patients who have 2 of those 5-factor score features. I don't necessarily utilize this in my practice, although every patient is different. Every patient's going to respond differently. We have a question here. According to the revised 5-factor score, which of the following factors is associated with increased risk of mortality for patients with EGPA? Age less than 65 years, cardiomyopathy, obstructive lung disease, and ENT manifestations. Great, those of you who were listening about 30 seconds ago got this answer correct. Yes, cardiomyopathy is a bad prognostic sign. The other questions there, age over 65, absence of ENT manifestations are better prognostic factors. So do you guys use the 5-factor score for monitoring disease? Do you use this tool or any other tools to help guide treatment or to monitor disease progression for your EGPA patients?
I can't say that I use this score per se. I mean, I think there's definitely, when the French came up with this, they not only looked at EGPA, but other forms of vasculitis like GPA and PAN, and what really stood out was the cardiomyopathy. But I tend to think of, when I think of patients, it's really, do they have severe or non-severe disease? Do they have life or organ-threatening manifestations? And that's how I proceed with my decision-making for initial therapy.
I mean, I consider it. I think that there is some good data when we're looking at, rituximab versus Cytoxan with, an elevated 5-factor score versus other medications. And I know you're going to go into some of the medication options. And Jason and I both worked on the guidelines. And so, they recommend using the 5-factor score and trying to use that in our treatment algorithm, or severe versus non-severe. Of course, I think it really just depends on the patient sitting in front of you in terms of what meds they're going to tolerate, what organ manifestations you're really trying to hit with the medication that you're using. So I'll use it a little bit, but more so just the overall clinical picture to decide.
Yeah. The data from the 5-factor score were an era pre-use of anti-IL-5 therapies, and so it's unclear whether or not the same prognostic factors are as useful, and they probably need to be reapplied and restudied.
Yeah.
I mean, do you use it at all?
I don't use it at all. I mean, clearly, there are things that are red flagged that might put you in life-threatening disease that you often are not encountering that in the outpatient clinic, at least in pulmonary. You might be in rheumatology here and there, have somebody come where you're like, whoa, and it's an outpatient, but often those are the patients we're seeing already in the ICU, et cetera. But, cardiomyopathy, active GN, et cetera, those are things that I'd be worried about.
But I think it's all things we know, right? Like it's things where your organs are affected and they're important organs. And so I think that's really what the point is in terms of trying to decide how aggressive to be in therapy.
Yeah, I mean, the way I look at it, you're going to treat all the manifestations of disease, and it's not going to change really your management, I don't think. I mean, we know that cardiac disease is bad, so we're going to want to address that specific component. So in terms of disease severity, I think Casey brought up in terms of non-severe versus severe EGPA. And the concept here is, does the patient have vasculitis with or without life-threatening or organ-threatening manifestations? The non-severe patients are generally without life or organ-threatening manifestations, generally things like skin manifestations, the asthma, maybe the pulmonary infiltrates. However, patients who have other organ or life-threatening diseases, including alveolar hemorrhage, glomerulonephritis, CNS vasculitis or stroke, mononeuritis multiplex, cardiac involvement, mesenteric ischemia, and obviously limb and digit ischemia, those are much more concerning, and you need to be very, very aggressive. So to me, what I look at is, does the patient have any of these severe manifestations, or do they look okay and they aren't quite so severe? Some of the things that we've utilized in terms of defining response to therapy, including using the terms remission, refractory, and relapse. And so I want to go over these so that everyone's on the same page. So remission is the absence of clinical signs or symptoms on or off immunosuppressive therapy. In general, for EGPA, we define it as having a Birmingham Vasculitis Activity Score of 0, so no active disease, and being on 4 milligrams or less of prednisone. Refractory disease is defined as persistent disease activity despite appropriate course of immunosuppressive therapy. So you're giving an immunosuppressant, the patient continues to have active disease manifestations. A relapse is any disease recurrence that it follows a period of remission. So you get the patient well controlled, and then they get worse again. And usually we define it as increasing symptoms that warrant an escalation in medications, whether it's increasing the dose of corticosteroids or whether it's adding on another immunosuppressant. So that's generally how we define relapse in patients with EGPA. For most patients, our goal is to prevent relapses and to get people into remission. We need therapies that will allow patients to have no significant symptoms and be as minimal a dose of therapy as possible. So when you guys determine a patient has EGPA and they're in remission, are occasional ENT or asthma flares acceptable? Do you consider those relapses? And what about, is it okay for a patient to have continued eosinophilia? Praveen.
Yeah, so, I would say, the occasional ENT or asthma flare is better than having, more systemic manifestations, but I wouldn't call it acceptable, and that, should dictate some escalation of therapy. It can be local therapy, which is, could be making sure you're, just like with our asthma care, that your patients are adherent with their inhaled corticosteroid and or the topical steroid to their upper airway, or depending on whether they're already on an anti-IL-5 or anti-IL-5 receptor agent, that might be an indication to do that. Again, with the question about what about continued eosinophilia, again, it depends on whether they're already on an eosinophil depleting biologic or not. There are some patients who have ongoing eosinophilia despite being on mepolizumab and occasionally even sometimes on benralizumab have some ongoing eosinophilia, which might dictate some additional therapy as well. We've talked about this before, about whether that would cause you to be, whether you are worried if somebody's got a leading edge of ongoing eosinophilia. Is that something you should be checking all the time or not? So I think there can be some practice variation here. I think I might do it a little bit more than you do.
I don't generally follow the eosinophil count.
Yeah.
I work with symptoms. If they have increasing symptoms, then I'll look at eosinophil count, sed rate, CRP, and other biomarkers. Yeah. What about the rheumatologist? You guys oftentimes dismiss the ENT and asthma manifestations and say, that's part of their asthma.
I disagree. No, I think that it really, because we label it as non-severe, but it is severely debilitating to some patients, right? And if you have constant asthma flares or ENT manifestations, it really impacts your quality of life. And so for me, it's really about what is the patient's quality of life, what are their goals, and are they able to achieve them? And so, occasional sounds not like I'm going to jump to adding necessarily more systemic agents, but it really depends on how that person's doing. And For the eosinophilia, I like my labs, and I'm going to check my eosinophil counts every visit along with their inflammatory markers. But I always tell patients I'm not going to treat the lab. It gives them some anxiety if the numbers aren't normal. But it will make me sort of screen them a little bit harder, right? I might ask just a little bit more questions, might make their follow-up a little sooner than I was planning on, just to make sure that nothing's sort of brewing or evolving. But I'm not going to necessarily escalate immunosuppression just for the lab value.
I think it's also important to differentiate what's damage from active disease. So ENT manifestations, sometimes that can be damage. Sometimes these patients can have chronic crusting that isn't especially active disease. So it's helpful getting the idea what their baseline is and how much patients know when it's above their baseline a lot of times. I agree totally with the eosinophilia. I follow it, but it's just one piece of the puzzle. You have to put it into the clinical context of everything else.
Yeah, and Jason, I really like that you brought up damage versus activity, because that's not something we always think about as pulmonologists. If you're in the EGPA space, you start to learn how you in rheumatology think about damage versus activity, but that's an important concept in EGPA. That's a little bit outside our normal comfort zone in pulmonary medicine.
Particularly one of the most bothersome symptoms, as we mentioned before, is neuropathy, and that is often the slowest to resolve. And so that's often the result of damage. And usually what we say is if you've had no other worsening disease, the biomarkers are under control, and something like neuropathy, and it's been there for 3 months or more, we move that more into the damage category rather than the active inflammatory category, unless the person has active biomarkers, elevated SED rate, CRP, or eosinophils that could be going on. So we have a lot of therapies that have historically been utilized for the management of EGPA. We generally, historically, have utilized steroids, and more steroids, and then we try to get patients to lower doses of steroids if the disease gets under control with the corticosteroids, and we do that by adding on other therapies, particularly immunosuppressants. But one of the first goals is to get the disease into remission. So traditionally implemented for remission induction include systemic glucocorticoids, and then for patients with severe disease, we often give cyclophosphamide, and more recently, in the last few years, we've been giving rituximab, particularly for patients who are ANCA positive, because rituximab will help deplete B cells and prevent some of the antibody formation. Other therapies that have been utilized historically for maintenance or to get patients to lower doses of corticosteroids include methotrexate, azathioprine, and mycophenolate. The only approved therapies, however, for EGPA are the two anti-IL-5 therapies, mepolizumab and benralizumab. And for these two therapies, there have been very good data that have supported the use of blocking IL-5. Praveen already told you why we think IL-5 is important in EGPA. IL-5 is the cytokine that's involved in the maturation of eosinophils, the activation of eosinophils, the proliferation of eosinophils, and can also play a role in terms of eosinophil survival. What mepolizumab and benralizumab do is they act on IL-5 or the IL-5 receptor, respectively, and play a role in terms of reducing eosinophils and consequently eosinophil activation and proliferation. Both of these therapies have been already approved for eosinophilic asthma, mepolizumab in 2015 and benralizumab in 2017. And now both of these therapies have been approved for the management of EGPA specifically. Mepolizumab at a higher dose than what's used for asthma, 300 milligrams once a month, was approved in 2017. And benralizumab, which is approved at 30 milligrams a month as opposed to 30 milligrams every other month after the first 3 doses, was approved just last year in 2024. These therapies are very effective as add-on treatment for patients with EGPA. They help facilitate corticosteroid withdrawal. They help get patients into remission, and they help manage some of the comorbidities associated with extra corticosteroid use. So one of the goals of treatment in patients with EGPA is to get patients into remission, first of all, keep them in remission, and then lower glucocorticoid dosing. What are the data to support the approval of mepolizumab and benralizumab in EGPA? Well, this study, called the MIRA study, was a study that added on mepolizumab at a dose of 300 milligrams a month to patients with relapsing or refractory EGPA. It was published in the New England Journal of Medicine in 2017, and it demonstrated that you could get a whole lot more patients into remission with mepolizumab on top of standard of care therapy, which included steroids plus or minus azathioprine, plus or minus methotrexate, plus or minus mycophenolate. We excluded patients who were on cyclophosphamide so as not to have more potential risk of adverse effects due to the cyclophosphamide. As you can see in the left-hand panel, over 30% of patients compared to about 3% of patients were able to achieve remission with mepolizumab compared to placebo. And when you look at the proportion of patients who had relapses, you can also see that there's a significant decrease in relapse in the proportion of patients who had relapses in patients treated with mepolizumab compared to placebo. That rate was cut down by about 50%. Benralizumab is an IL-5 receptor antagonist, and it was been approved for asthma in 2018, but it works slightly differently compared to mepolizumab in that it binds the IL-5 receptor. Not only does it prevent IL-5 from binding to the receptor and prevents it from activating in eosinophils and causing maturation of eosinophils, but also the body recognizes benralizumab on the IL-5 receptor as foreign, and that can lead to antibody-dependent cell-mediated cytotoxic effects that can result in depletion of eosinophils. This past year, a year ago at ATS, I think we presented the Mandara trial, which was a head-to-head study comparing mepolizumab to benralizumab. It's one of the few head-to-head trials that's been done with biologic agents in asthma and or in EGPA. In this study, we tried to demonstrate that the goal was to see whether or not benralizumab was non-inferior to mepolizumab. And what we showed was that 58% of patients were able to achieve remission with both mepolizumab and benralizumab. So benralizumab was deemed to be non-inferior for patients with EGPA, with relapsing or refractory disease, in terms of induction of remission. Both of these therapies have been shown to be quite safe. And in this trial, this head-to-head trial of 140 patients, see, many patients had adverse effects. It was done during the COVID era. But one of the amazing things that we saw was, in addition to both drugs being relatively safe and no new safety signals emerging, was the proportion of patients who were able to come off of glucocorticoids completely. 41% of benralizumab patients and 26% of mepolizumab patients were able to come off of glucocorticoids. And that's huge for our patients because of the adverse effects that they experience. Now, this is an exciting time because we now have mepolizumab and benralizumab approved. They're both effective therapies, they're both safe therapies, but there are other therapies that are in development. Depemokimab is an every 6-month, ultra-long-acting anti-IL-5 therapy. As you may have seen a couple of months ago in the New England Journal of Medicine, it was studied in asthma, and as I presented 2 hours ago in the pooled data analysis with depemokimab, in patients just with asthma, there was a 54% reduction in exacerbation and improvement in patient-reported outcomes. So depemokimab is being studied in what's called the OCEAN study, and that study has completed enrollment or is near completion of enrollment, and we should have results sometime in 2026. Other therapies that are being evaluated included other anti-IL-5 therapy, a JAK inhibitor, and a TSLP antagonist, tezepelumab. Tezepelumab is also approved for asthma, patients with severe asthma. It blocks TSLP, which is an epithelial cytokine that's atop of the inflammatory cascade and plays an important role in terms of activation, proliferation of Th2 cells and ILC2 cells that can result in increased production of IL-4, 5, and 13. So the racemate study is being conducted primarily in Europe by Salman Siddiqui and colleagues. And we know as well there have been case series of patients with EGPA treated with tezepelumab who've done extremely well. This brings us to the guidelines. What do the guidelines advocate in terms of the management of patients with EGPA? So we've got the 2021 as American College of Rheumatology and Vasculitis Foundation treatment recommendations, and then we have the European League Against Rheumatism, or EULAR recommendations. The 2021 ACR Vasculitis Foundation recommendations recommend evaluation for active severe disease versus active non-severe disease. For active severe disease, the recommendation is to give IV or high doses of glucocorticoids plus cyclophosphamide or rituximab. What's active severe disease? Again, it's life-threatening or organ-threatening disease such as cardiac disease, central nervous system involvement, kidney involvement, and the like. In patients who have non-severe disease, it's recommended that you start off with glucocorticoids plus an anti-IL-5 therapy. These guidelines came out before benralizumab was approved, but that would be a reasonable option as well, either mepolizumab or benralizumab, given their non-inferiority to one another. Other options that are proposed, which have some efficacy, include methotrexate, azathioprine, and mycophenolate, or rituximab, or in some patients, glucocorticoids alone are sufficient in terms of getting patients into remission and making sure that they do well. What do you do in terms of patients who achieve remission on cyclophosphamide? Well, it's recommended that you get patients off of cyclophosphamide because of the complications, increased risk of malignancy, hemorrhagic cystitis, immunosuppression. And so it's recommended once you get a patient into remission, you switch them to methotrexate, azathioprine, or mycophenolate. And patients with severe disease who relapse after remission with cyclophosphamide, those patients should get IV or high-dose daily PO glucocorticoids and rituximab. Notice they don't mention the utilization or potential utility of anti-IL-5 therapies, and that's something that we can discuss in a few moments. For non-severe disease, it's recommended for patients who relapse on methotrexate, azathioprine, or mycophenolate or glucocorticoids alone, add mepolizumab or an anti-IL-5 therapy. Again, these guidelines were developed before benralizumab was approved last year. For non-severe disease who relapse on mepolizumab or rituximab, then you can consider any of the other alternative immunomodulatory approaches like methotrexate, azathioprine, etc. What does the European League Against Rheumatism recommend? Well, this is from 2022, and the first question they ask is does the patient have relapsing or refractory disease? The answer is no, just start glucocorticoids. And the goal is to taper glucocorticoids to an individual target, ideally getting the patient off of glucocorticoids. If you get the patient into remission, well, then you can stop therapies. If not, then you should consult an expert center and consider alternative therapeutic options. What if the patient does have relapsing or refractory disease? Well, for those patients, mepolizumab is actually recommended by the EULAR recommendations to combine with glucocorticoids, but if there is organ or life-threatening disease, they recommend starting with cyclophosphamide or rituximab in combination with the glucocorticoids. In terms of maintenance of EGPA remission, the recommendations from the EULAR group are to switch to or continue azathioprine, methotrexate, mepolizumab, or rituximab and continue glucocorticoid therapy once you've achieved remission. So switch down to the lesser toxic therapies. If a patient achieves sustained remission, well, if they don't, if they're relapsing, you need to go back to the beginning and induce remission in those patients. If they do have sustained remission, and if the individual glucocorticoid target has been reached, then you should assess the patient's individual risk factors, their comorbidities, and their patient preferences. And then you need to use shared decision-making to have a discussion with the patient whether you should continue the therapy, stop the therapy, or perhaps increase the interval of dosing for these therapies. So we just mentioned that benralizumab has been recently approved in the last year. Where do you see that therapy fitting into these treatment algorithms now that it's FDA approved for the treatment of EGPA? And does this change based on disease severity? I want to hear from the rheumatologist first. What do you guys think?
I think it's great that there's another option that blocks IL-5. I think that you could easily swap out, mepo and benralizumab based on the studies wherever it fits in those algorithms. But I will say, even being part of developing those algorithms, I don't use them to the T on every single patient. I think there's probably roles for mepolizumab in severe disease or benralizumab, and so I think it really depends on what the active clinical manifestations are. So I will use, rituximab or cyclophosphamide for induction, and then depending on what's going on with the patient in front of me, I might use, methotrexate, azathioprine, one of those other sort of DMARDs along with an IL-5 blocker. It really depends on what's happening with the patient, but the fact that there is more options for me is really exciting. In terms of disease severity, again, it really has to do more, in my mind, with like eosinophilic manifestations and what the patient's comorbidities are and what they're looking like.
Yeah, I agree. In patients that have severe disease, I'm still a little bit hesitant with starting with IL-5 therapies. Maybe it's just the rheumatologist in me, and I'm used to cyclophosphamide and rituximab a lot more. I really like cyclophosphamide for patients that have cardiomyopathy, whereas rituximab, the ANCA-positive patients, treating them with rituximab. But I definitely think benralizumab, I could swap it out for mepolizumab and having those other options, primarily in non-severe disease. But I will say I am having patients that are on rituximab that their asthma is not well controlled. I'd be interested to hear your guys' experience on this, where adding the IL-5 on top of rituximab to control the asthma. I wonder what your thoughts are.
Yeah, I think it's a good option for a patient like that. Obviously, we see a different mix of patients, and it's not often that I will follow somebody who's on maintenance rituximab alone with asthma who hasn't already, seen an anti-IL-5 receptor biologic. But that said, I think that's a great candidate for add-on therapy, and I think that basically follows the guidelines, the ACR guidelines anyway, right? Because at that point on maintenance disease, you're considered non-severe. It's not quite, slotting into IL-5 therapy in the, in the first box, but more down, I think it fits into, some ongoing symptoms despite maintenance rituximab. So yeah, I think it's completely reasonable.
So I do want to talk about this a little bit because I think it's an important area for discussion about the use of the anti-IL-5s versus some of the recommendations in the guidelines. The reason we didn't study acute disease is because we were a little bit nervous, and there's a standard of care, and we're trying new therapies like mepolizumab and benralizumab in these patients. And so I could see why, from a data generation perspective, you'd say, well, they weren't included in the study. On the other hand, I do want to point out that there have been no randomized, double-blind, placebo-controlled studies with cyclophosphamide or rituximab in patients with EGPA. So do you guys want to comment on that?
That and the fact, rare diseases, is hard to do large trials, all this stuff. But yes, that and the fact that there is good real-world data with some of the IL-5 blockade agents, and looking at some of those more severe manifestations, and people get better. And so I, again, am more hesitant with like I'm not going to probably just use an IL-5 blockade agent in a person with a cardiomyopathy, but I'm pretty quick about getting it on board along with an induction agent, another induction agent.
I will say that the anti-IL-5s do result in, if we think that the eosinophil is the driving factor in a lot of this disease, the anti-IL-5s reduce the tissue and blood and tissue eosinophils. We think the tissue, but certainly the blood eosinophils quite quickly within, as certainly steroids do the same thing. And one of the major goals of giving drugs like cyclophosphamide is to deplete the bone marrow of the eosinophils.
Yeah, I don't think anybody is arguing at this point for replacing induction therapy with mepolizumab or benralizumab, but I completely agree that as an adjunct potentially quite early agent, yeah, I think it's completely reasonable. There, yeah, it's not on label, but the downside risk is relatively minimal as well.
Yeah, and I will comment that with randomized trials, that's always the risk, right? Like, I mean, some things fall earlier in an algorithm because you're basing your guidelines on whatever trials exist, and so if you never tested it, you can't prove that it didn't work, right? So that does somehow shift some of these algorithms in ways that aren't necessarily clinically the strongest necessarily decisions. It's
there
based
may
on
be
the
also
evidence available.
limitations in terms of access to these medications quickly in that urgent setting, but that's something that could probably be addressed and or worked on. So one of the key goals of these therapies is to reduce systemic glucocorticoids in patients with EGPA because of all the side effects, whether it's cataracts and glaucoma or the risk of cardiovascular disease, weight gain, sleep apnea, infections, and then all the acute manifestations as well. There's acute weight gain, and then there's anxiety, depression, diabetes, cardiovascular disease, hypertension, all of these, osteoporosis, all these are major risk factors. So one of the major goals of management in patients with EGPA is to get patients off of glucocorticoids or to the lowest dose possible. And in the MIRA trial, one of the things that we demonstrated was that we were able to get patients down in their corticosteroid dosing by 50%. Patients treated with placebo started off at 11 milligrams a day and ended up at 11 milligrams a day by the end of the 50-week, 2-week trial. In patients treated with mepolizumab, they started off at 12 milligrams a day and ended up at 5 milligrams a day. So we saw about a 50% reduction in steroid dosing. And I think that's really, really important because steroids are the major, major complaint that patients have. In the benralizumab study, when we compared glucocorticoid dosing in patients treated with benralizumab versus mepolizumab, we saw that benralizumab therapy facilitated steroid withdrawal, and 50% of patients achieved a prednisone dose of 0 milligrams during the treatment phase. So that's another important component. This is from a 10-person study that we did at National Jewish that we published a couple of years ago. In the Mandara trial, we also demonstrated that 41% of patients treated with benralizumab and 26% of patients treated with mepolizumab were able to come off of glucocorticoids. When we look back at the MIRA study, in the placebo group, only 3% of patients were able to come off of glucocorticoids completely. So that's huge. Going from 3% going down to 0 up to as much as 41%. And in the 2-year extension of the Mandara trial, which I just presented a couple of hours ago, we demonstrated that we could get over 40% of patients who are on their second year of therapy, mepolizumab to benralizumab or benralizumab to benralizumab, off of glucocorticoids. Do you guys want to comment on that and the ability to discontinue systemic glucocorticoids? And what's an acceptable steroid dose in your mind? And again, I want to hear from the rheumatologist first. What's an acceptable steroid dose, and what do you think about whether or not we can get patients off of glucocorticoids?
Well, I will say I think it has been easier clinically in my experience to get patients off of glucocorticoids with these agents as opposed to the older agents. So definitely that fits with the studies. There are still some patients that require some glucocorticoids. I typically aim for 5 milligrams or less. So for me, what quote unquote is physiologic doses of prednisone. So what do you think, Anisha?
Yeah, I mean, I want to get them off if I can, right? And I think now we have a lot more options to get them closer to that. I think part of maybe the differences in the trials is that, the first one was the first IL-5 being used in EGPA, and, there wasn't a head-to-head comparator, so people were probably a little bit less comfortable really pulling down the prednisone. And I think with the more recent trial, and I didn't hear the extension data, but that's great. The fact that you're able to get that large of a percentage over 2 years, off of steroids is a major win. My goal is always to get them off steroids, right? But there are those people where you go from 3 to 2, back to 3 to 2, and you just can't do it. But I think in my mind, the goal is always 0. Acceptable is patient defined,
Praveen, I know you like to keep your patients on steroids, right?
Oh yeah, I love them. No, I think again, sometimes there's some anecdotal stuff. I think I'm able to get, based on my patients that I'm seeing, maybe the particular patient characteristics, maybe a little more often than what those numbers are, both from Mandera and from Mira. And again, my personal experience, it does match that benralizumab. I do seem to get a few more patients completely off of systemic corticosteroids than with mepolizumab, but I think there's definitely some patients who get left behind and still would have some OCS requirement. Clearly less is better also if you can't get completely off as far as long-term, long-stream downsides of chronic OCS use. So. But I think many patients can get off of systemic glucocorticoids eventually.
Yeah, there's probably differences between the patients that you're seeing and the patients that the rheumatologists are seeing.
I think that's right.
And I think that, it might be a bit more challenging in the rheumatology practice because those patients often present with more systemic manifestations with regard to their EGPA. One other study that's been published is David Jackson's cohort from the UK, where they used anti-IL-5 therapies and got close to 70% of their patients off of glucocorticoids. So you do need to try, and many patients are anxious about it. I can tell you, the early studies, we were anxious about getting people off of glucocorticoids, but if you don't try, then you won't achieve. So that brings us to discussing bidirectional communication, shared decision-making in our patients with EGPA.
Yeah, I think that's me.
I think it's you.
Yeah. Give me that clicker. All right, so I think Anisha, one of you, or Jason, one of you referred to shared decision making earlier in the talk, but clearly, this shared decision making is critical with EGPA. I can think of a couple of my patients who I've had extended conversations with who are doing well on biologics, who want to reduce their biologics if possible, and that's off-label, but they'd like to try to do less medication if at all possible. So there's two sides. There's us as the clinicians. We just talked about guidelines. We have our own anecdotal experience, which we've all shared. We look at the evidence. We have our goals in mind, but the patients and their families, they have their particular values and what, as far as the amount of medication they want to be on, preferences, and then for some folks, doing regular injections is resource intensive. It's hard for them to do that. So we want to be patient-centered and collaborative in our therapeutic choices. So here's another question. What are some of your strategies for shared decision-making when discussing biologic therapy with your patients? Mike, since you just got to ask a lot of questions, maybe I'll ask you to answer this one.
Yeah, I think you want to give a lot of options and be frank about what the goals of therapy are, and what are the pluses and minuses of the therapies. You also want to take into account patients' perceptions of these different therapies and their value systems, not to mention their economic status and the feasibility of affording some of these medications if that's an issue. So these are all things that you need to talk about. Understand what are the patient's perceptions, what are the patient's fears, give them the data, ask them what their thoughts are, get their perspective, answer their questions, really have an open discussion and ask them what are their concerns and fears. And most patients will be open and honest with you.
Anything additional from either of you?
No, I think you covered all the really main points. You just want to be open and make sure they feel comfortable expressing what they can and can't do and why they're worried about certain things.
Yeah. All right. So just briefly, as far as barriers to use of biologics, we covered some of this in discussing shared decision-making, but these are costly medications. There can be a lot of difficulties, which we all know well, in navigating insurance coverage. We don't have definitive biomarkers to guide treatment, when to stop treatment even. There's some potential side effects, though these are quite well-tolerated medications. We talked about logistics and access barriers. And then there are some patients who have needle phobia and prefer not to take injection medications. So let me end here with key takeaways from everything that we've talked about. It's been a pleasure being on the stage with all of you. EGPA is not only difficult to diagnose, but due to its rarity and heterogeneity, it can be challenging to manage. EGPA carries a high disease burden, symptom burden, and a higher risk of mortality compared to the general population. We've talked about biologics and that they've demonstrated efficacy and safety in the treatment of EGPA, and we've talked about OCS and systemic corticosteroid sparing with biologics, and that it takes a village, a multidisciplinary approach to care for patients with EGPA who might have multiple different organ manifestations. So with that, we have post questions, which we'll now go through. That are the repeat of our initial questions. So let's start here. Which of the following FDA-approved therapies for the treatment of EGPA were developed to target the underlying pathophysiology that is involved in the activation, recruitment, and infiltration of eosinophils? 1, benralizumab, mepolizumab. 2, mepolizumab, tezepelumab. 3, omalizumab, tezepelumab. 4, benralizumab, omalizumab.
If you guys don't get this one,
Michael cry.
Great, good job, everybody. And thanks to the house band for their incredible music. All right, next question. Okay, so we did better after.
Yes.
Awesome. Warms my heart. All right, post-test question number 2. According to the 2022 ACR-EULAR classification criteria, which of the following criteria increases the likelihood that a patient has EGPA as opposed to another type of small vessel vasculitis? 1, hematuria. 2, mononeuritis multiplex. 3, otitis media. 4, positive test for C. ANCA.
I think I know this one.
I think we do. Ooh, got a split vote. So some people said mononeuritis multiplex increases the likelihood that a patient has EGPA, and others said positive test for C. ANCA. So so we got before and after 54% for mononeuritis multiplex, which is the answer for the ACR-EULAR classification. Remember, the C. ANCA is less associated with EGPA, so it's negative points on the ACR-EULAR classification. It's always a little confusing because of the C. ANCA versus P. ANCA. So the answer there is 2, mononeuritis multiplex. All right. Post-test question 3. In the phase 3 Mandara study, which of the following is true regarding the efficacy of benralizumab in patients with relapsing or refractory EGPA? 1, benralizumab was superior to placebo for induction of remission. 2, benralizumab was non-inferior to mepolizumab for induction of remission. 3, treatment with benralizumab resulted in a longer time to first relapse compared with mepolizumab. 4, treatment with benralizumab resulted in a shorter time to first relapse compared with reslizumab. All right, hit it.
I think I know this one.
Would you say it's from Wechsler at all? Okay, people said 80% for after with 56% before, that's right. So the Mandara study was a non-inferiority study compared to mepolizumab. So the answer is question 2. And Dr. Wechsler was being modest. He led both the MIRA and the Mandara studies, as you might have seen in small print at the bottom of the slides. Okay, post-test question 4. Ellen is a 51-year-old woman who has a 7-year history of asthma and a 2-year history of CRS with NP. In the past months, she has experienced worsening asthma symptoms necessitating an ER visit and has noticed persistent cough. Her laboratory results show significant hypereosinophilia, 74-96 cells per millimeters cubed. She is currently on prednisone 10 milligrams per day, along with ICS and ALABA. Which of the following would you recommend at this time? 1, continue current medications. 2, decrease prednisone to 7.5 milligrams per day and add a biologic. 3, continue current medications and add a biologic. 4, discontinue prednisone and start cyclophosphamide.
Those questions.
Okay, so 2/3 of you said continue current medications and add a biologic, and pre and post. That's what most people said. I agree with that answer, and yeah, okay, I think that's a reasonable answer. Okay, great. Post-test question 5. Approximately how often will you now recommend biologic therapy for patients with severe EGPA? Oh, 1, never. 2, 25%. 3, 50%. 4, 75%. 5, 100%. 6, I do not manage patients with EGPA, period. Okay, so really split vote, and I think this is how often you would do it.
It's the rheumatologist versus the pulmonologist.
Yeah, exactly, yeah. And then some people here did not, yeah, okay.
Stop managing patients with EGPA during the talk.
So just to put a fine point on it, there's the guideline recommendation, does not have biologic therapy, depends on how you define a biologic, but that said, we talked about, how you might, want to have a little bit of a gray area there. Okay. Question 6. Approximately how often will you now recommend biologic therapies for patients with non-severe EGPA? Same choices. Okay. Some movement there.
44% will now do it 100% of the time.
Yeah, and 22%, the 44 to 22, and not managing patients with EGPA. So people went outside and took care of some, and then they came back.
Yeah, amazing.
I think it's awesome. Yeah, all right. Okay, that's it. So we're gonna have the question and answer now.
Yeah, we have a couple of questions that came up on the question cards. So one of the questions, which I'm curious to hear what you guys think, the role of BAL in diagnosis in patients with eosinophilia, pulmonary infiltrates, like how do you look at that when you're thinking about EGPA, HES, eosinophilic pneumonia? That's sort of the first part of that question. Where do you use the BAL, and how do you interpret that?
Yeah, I think it depends on, do they have peripheral eosinophilia? Is it critical to do a bronchoscopy in those patients? If you're uncertain about the diagnosis, EGPA is a clinical diagnosis. It's, asthma, eosinophilia peripherally, maybe plus or minus pulmonary infiltrates, sinus disease, vasculitis, plus or minus ANCA, neuropathy, et cetera. If I'm uncertain about the diagnosis, then I might do a BAL, but the major reason I do a BAL and do a bronchoscopy is actually to exclude other things, exclude infection. I don't want to miss infection. It can be obviously supportive if you get BAL eosinophilia. It could, if you don't have other manifestations, extrapulmonary manifestations, it could be a good indicator of chronic eosinophilic pneumonia as well. But the major reason I would do a bronchoscopy would be to look for infection or malignancy, I suppose, as well.
Are you guys ever using it to assess response to treatment? That was another part of the question.
Never.
Never. Yeah. I mean, it's very rare that I feel like I need a BAL eosinophilia as an adjunct piece of data to make a diagnosis. Often non-fixed infiltrates in concert with systemic eosinophilia with other consistent syndromic manifestations kind of speak for themselves.
Yeah. And another question was about following up patients with EGPA who are on biologics. So how do you specifically follow them up? Aside from clinical assessment, are there any specific blood tests that you follow regularly, spirometry if they have asthma, questionnaires? Kind of what's your interval on doing these different types of studies, and how often are you doing them? And I think
we may have different perspectives on this from rheumatology and pulmonology standpoint. So, I'm checking the basic labs. I do follow their eosinophilia. I'm not following their ANCAs and the ANCA positive patients, but I do follow their urine. If they've had like lung granulomas, I do like to follow up on that with serial imaging. And then, you know, you guys are helping me out with PFTs, which I think are very helpful as well. So.
To me, I'm going to follow the manifestations of disease and the abnormal blood counts that were, or other imaging modalities. If they were abnormal before, I will continue to follow those features. The things that I utilize on a relatively routine basis are sedimentation rate and CRP, just to see if there's active inflammation. If they are clinically stable, I don't do most of those things. I might check lung function because we do that on pretty much every patient. I'll only check imaging if they have symptoms or if they had not cleared their prior pulmonary infiltrates. Other things that I might check are if they previously had cardiac disease manifestations, I might follow up with an echo and or a cardiac MRI. But really it's going to be dictated by what's going on. If they're on an anti-IL-5 therapy and they are not symptomatic, I don't necessarily check labs at all, and I most certainly don't check eosinophils. Eosinophils are almost always down to extremely low levels. Praveen?
Yeah, you know, I think I always find this question interesting because there's a way to do things well as a vasculitis center, and that involves, you know, routine checking of labs. But, you know, this is such a disease that has this kind of component of being, you know, severe asthma and other non-vasculitis systemic manifestations, with having some patients who have systemic vasculitis. So, you know, yeah, I'm probably more on Mike's end of things, but I do, you know, find that sometimes when I'm co-managing with my rheumatology colleagues and they're getting more regular labs, there are some interesting things that come up that are actionable over time. But that said, I'm, you know, probably getting spirometry once a year unless, you know, somebody's having more respiratory symptoms, and then acting based on symptoms.
I will add the cardiomyopathy, you know, you want to catch that, and I don't know that we have clear guidelines on what to do to screen for that. I have been getting, in my ANCA negative patients, I've been getting echoes maybe once a year or so, but that's not evidence-based per se.
You know, there are ANCA positive patients who have got cardiac manifestations, so I don't necessarily discriminate in the ANCA positive or ANCA negative patients. Patients who are short of breath, have chest discomfort, you know, they'll get usually a baseline cardiac workup that includes troponin, EKG, and echo. And if any of those are abnormal, I go to cardiac MRI.
Yeah, I usually start with echoes at baseline, and then of course if there's something abnormal, I'll follow it regularly, but then just based on symptoms. And I do obviously more along what Jason does here, where I'm checking, you know, urine and inflammatory markers and all the labs every about 3 months. Those were the main questions.
Those are the main questions.
I think,
All right.
I think
Any other
that's
questions
it.
from
Any
the
other
audience?
questions?
Anybody want to shout out?
All right.
Great.
Thank you all for attending.